Adam, thank you so much for joining me.
Thank you. I'm happy to be on.
I'm really thrilled, and I'm very grateful because uh, I tell you what, the least popular of my blog, my articles, my blogs, my pieces, my tweets, the things that get no traction whatsoever, you know, have to do with this question of physician-assisted suicide.
Yeah,
So
yeah.
I have a feeling that uh, I have a feeling nobody wants to talk about it, and I'm frustrated because I feel strongly about it. I think it's a very important issue. I think it's
Yeah. It's
important.
it's
Right, go ahead.
it's funny after we made plans to have this conversation, and I was kind of walking up and down my hall at work, you know, going in to ask people about it, just to talk about it, get people's opinions. Everybody sort of when I brought it up, they're like, "Oh God." So
Why do you think
I
that
think you have a
is?
good read on the pulse. Well,
Yeah,
I think that I think that even people, and I'm sure you're different, knowing you a little bit, but I think even people who think they have opinions are uncomfortable with their opinions. So I think people are so conflicted that unlike other parts of their life where they're able to take a very hard stand, this is one of those issues that a
yeah,
lot of
it's
people aren't sure
interesting.
what they think.
You're right. I mean, it's I find that it's almost easier in a way. I don't get into it because
Yeah,
I don't want to attract, be drawn into big conversations. But I think the question like abortion is,
sure,
in a way, people have strong opinions
sure,
generally
sure.
one way or another, and they can articulate them and so forth.
Yeah,
Whereas with this, you're right. You're absolutely right. People, I think they don't know where to start or
right, right.
how to
I
deal
feel
with
like
this.
I feel like when I have good conversations with things, I heard this statement once that I like people with strong opinions lightly held, um, and that's those issues where people can come in and they say this is how I feel, but they're sort of happy to change their opinion. And I think when you talk about abortion, that tends to be strong opinions, strongly held. And I think in this, when you talk about physician-assisted suicide, it's often sort of maybe weak opinions strongly held or something. So
Right.
it doesn't open itself to
That's
conversation.
interesting. Yeah, you may be right. But I mean, I think I have um, a very strong opinion about it. I mean, I'm
Yeah,
sort of categorical
yeah,
against physician-assisted suicide or
yeah,
physician-assisted dying or whatever the phrase we want to use. It doesn't matter to
yeah,
me.
yeah.
Um,
How
I
did you
think
come
it's
to your opinion? Like, where did that come from? How long have you felt that way?
it's interesting. It's more I didn't think about it through medical school. Never thought of
Yeah,
it.
yeah,
I remember in medical school, Kevorkian would be on in the news once in a while.
sure.
In those days, I had no opinion. I
Yeah,
really couldn't care less.
yeah, yeah.
And then it wasn't brought up in the curriculum. It wasn't an issue. So
Right.
I had I was completely agnostic about it. Perhaps a little bit. If I try to remember, I may have been a little bit sympathetic
Okay.
to the idea.
Okay.
Um, but in those days, I was completely um, neutral on abortion as well. I mean, I was
Yeah.
neutral on a lot of moral issues.
Yeah.
I was just trying to get through, pass the exams and get through and get ahead. And I
I
didn't,
I got
it
to
was
study. Don't give me anything to actually think about here.
right, exactly. And it was never, we were never confronted with those
Yeah.
questions. I mean, it
Yeah.
was never.
Yeah.
They were avoided, carefully avoided
Yeah.
in the conversation. So,
It's interesting.
yeah.
I think I went into this actually um, more opposed to it, probably both by upbringing and by the feeling that, I'm going into medicine because I want to be a physician, I want to be a healer, I want to have absolutely, no part in playing a role in someone's, demise, death, whatever.
Hmm. Hmm.
Um, and sort of grew to being much less definitive. I think probably through residency training was what turned me.
Right. And what I mean, some experiences with people languishing and the
I think that was it. I think that, I mean, I think we're probably close to the same age. I did residency kind of 93, 90 to 96. 93 and 94 were kind of peak, HIV death periods. Um, kind of terrible time, horrible illness, horrible suffering, little we were able to do for people. And I recognized that with those patients and also some other people in my experience, I actually can remember someone who always comes to mind with really horrible idiopathic pulmonary fibrosis, um, where although we were certainly not even considering physician-assisted suicide, euthanasia, assisted dying, whatever you want to call it,
Mhm.
I recognize that in our care, we certainly did things to make people comfortable with, which hasten dying. Mostly pain control, opiates, other sort of respiratory depressant medications. Um, and I think that opened the door for me a little bit, that I would recognize that, boy, we're doing some things which we all feel okay with, which probably changes the course of someone's, illness, life over hours to days, which made thinking about doing something which changes the course of someone's illness and life over the course of, I don't know, days to weeks, not as terrible to me.
Right. But I think there's a distinction
Sure.
um, in terms of the intention, right? I mean, if you relieve pain with opiates, or relieve respiratory distress with opiates and things
Yep.
like that,
Yep.
and as a secondary effect, it happens to bring about death. Um, that generally, that's considered, I mean, at least in my book, or in the book that I
Yeah.
follow, it's
Yeah.
considered okay,
Yeah.
because you're not intending to kill the patient or to help the patient kill themselves, or
Right. Right.
that sort of
No,
thing. So
I think that's a great point, and I absolutely take that. I mean, the intention is one thing, but clearly, you can't hide from the fact that um, that you are, affecting the outcome, and whether that is your intention or is sort of a side effect or benefit, it's the same. I think what bothers me about it, and I am I am not terribly fundamentalist about this, is that um, when in that part you have somebody who is already suffering, um, and you're treating that suffering, you're ending that suffering. Often, when we're thinking about physician-assisted suicide, it's earlier in the course, and so you're
right.
almost avoiding imagined suffering, which hasn't happened yet. And that's the part of the jump which is hard.
Yeah, no, it's highly problematic,
Yeah.
as far as I'm concerned. But I think the distinction between the intention that I was mentioning, it's on the outside. I mean, obviously, it's if you have an alien who would observe, they may not see the difference, right,
Yeah.
between
Yeah. Yeah.
somebody
Yeah.
who's committing euthanasia versus somebody who's palliating, or providing symptom
Yeah.
relief,
Yeah.
and in the course of things, the patient dies. But it's a real difference, and it's a crucial difference,
Yeah.
and the laws that are being passed. I mean, this movement that has really built momentum and is now
Yeah.
really sort of on the ascendance here.
Yeah.
Um, Clearly, wants the intention to be okay, meaning it's okay to intend the death of the patient, or to assist. I mean, obviously, it's assisted dying, so it's providing with the patient, at least uh, currently in North America. Those are the laws. The laws that are in the
Right.
book are the books that uh, give patients the means to kill themselves
Right. Right.
um, with that intention. And
Yeah.
that, I mean, I can't imagine it's, and I find it. Uh, I find it threatening to the profession of medicine, and here's where I think I was going to say that you and I disagree on some things related, to evidence-based medicine and so forth.
Yeah.
We've had, but at the same time, we're on the same side in terms of trying to defend or preserve something objective about the practice of medicine.
No question.
Right. So when you rail against the widespread adoption of a device, with little evidence to back it up and so forth, it's because you think there's something objectively good in what we do.
Yes.
It's not just a matter of the doctor deciding that that's good, that makes it good,
Yeah.
or a matter of the patient deciding, well, I want that device, and therefore, we should let you have it. You're trying to defend something, that's objectively good. And here, the moment we open the door, we allow, assisted dying to be part of a medical practice, then we bring in something that is, we make medicine completely subjective at that point,
Yeah.
right? I mean, it's sort of
Let me, so you're very good at this because you get to the point that I am most uncomfortable with. And it is true. I probably overvalue medicine and the roles of physicians. And the reason I do what I do, and the reason I continue to be proud of what I do, and the reason that I can, get up every morning and go to work is I absolutely feel like, I am doing, good for mankind, for my patients, for my fellow humans, no question about it. Um, and so when I think about this, and so, on the surface, boy, and the reason when I was going into medicine, I was like, I will never be a part of this, is because this is like anathema to that stance, right?
yeah.
So I guess when I think of where this is, um, I think the steps I've gone through is one, what I already said, is that, look, we already do this. We already accept that we do this. And we're just sort of, moving what's allowable a little bit. And I don't buy the intentionality argument, because I think it's the ends that's important. And it's funny, when we were having this debate on Twitter, somebody threw in a comment about how, like, oh, no, when you're just treating pain, that's not going to shorten life. And I was like, that's the most ridiculous comment I've ever heard. That's like wishful thinking, and
Right.
and there's no way to study that. That person quickly didn't respond and probably unfollowed me after that. Um, the second point is that I try to think of this as, maybe we are still doing what's best for the patient. And I think of it as doing the best for the patient and not what the patient wants, because, you and I have had this discussion about, often what the patient wants is wrong, right?
Mm-hmm, mm-hmm.
And uh, being a good doctor often means no, or at least saying, that's the wrong decision. Obviously, I'm going to still care for you, but I'm certainly not writing a prescription I don't think is appropriate. But it's your life. You can do what you want, but I'm not going to be party to it. But I think in some settings where, boy, we've done we know you're going to die from this. We've done everything we can do to make you as comfortable as possible. But when we know you're going to die in a month, why make you suffer for a month when we could make it so you only suffer for 4 days?
So
Um,
you think that that assisted dying brings about the end of suffering?
so I do think it brings about the end of suffering for a patient. I'll go back and ask you about that.
On the basis of
And
what evidence,
yeah.
Dr. Sifu? I'm
We
serious,
can't get
actually.
too existential here.
No. Why not? I mean, if we're going to be existential,
Yeah,
I mean, this is the time to be existential,
absolutely.
right?
Okay, I'll give you that. I do think that bodily suffering ends with death, and I have to take that as my stance. That's what I believe, and I think that a patient who requests this, that is in that person's belief system too, so they are comfortable with it.
Yeah, okay, but really, you're not being scientific as you ought to be, because when you say that bodily suffering, and I'm not sure what that means, bodily suffering. I mean, if you make a distinction between the body and the soul, or the body and the mind, or the body and the self, or whatever distinction, the suffering pertains to the self, or to the person. Whether the person is just a body, or there's more to it. I mean, we should be agnostic about it, right? I mean, if we're going to be scientific, and therefore we should be agnostic about whether suffering ends or not. And you're right that most patients who are requesting suicide or assistance in death and whatnot, seem just by the mere fact that they're asking to have taken a position on it. But if we wanted to be consistent with our approach, you would give informed consent, and you say, by the way, there's no evidence. We don't know if this will end your suffering or
Sure,
not.
sure. And this
And
is
and
this is
and, and certainly, throughout, I mean, for a large swath of the population, uh, you know, people believe in an afterlife, and historically, people have believed in an afterlife for a long time, and so forth. And so, if we're going to be scientific, we're going to say, listen, we can't have a position one way or another. There's nothing in medical science that tells us what happens next, and so,
Shall
if possible,
I will absolutely accept that, and
okay,
it's an argument in both directions, right? I
right.
mean, you can't say with any certainty that
Yeah,
you're suffering.
but I want to be a medical conservative, Adam. So, if in the absence of evidence, I want to be conservative,
Um,
right? So,
um, I'm with you 100%. You as the patient need to make the decision, and you may prolong your suffering by doing this, or you may shorten your suffering by doing it. I don't know,
right.
and that's for the patient to decide. Um, the other thing is, when we talk about suffering, um, what I've what I've recognized in my practice is that in the in my patients, as they're going through the final stages of their disease, um, the uncertainty of what's ahead is very troubling and very painful for a lot of people. It's often a pain that I can't assuage because I don't know what's ahead, and I say, "Listen, I'm going to be with you. I'm going to do everything I can to give you, a dignified, as tolerable death as possible." Um, but I think actually, and I again, I mean, we don't know any of this, but I know that some of my patients, they've actually said to me that, if I knew that in Illinois, this was an option, it would give me some certainty of, boy, if things got bad enough, I'd have a way out, even if they didn't use it. And that's something I could see being positive for this.
Yeah, I mean, I could see it. I mean, that was the argument that Jerry Brown made when he signed. He passed the law in California.
Yeah,
He said, it provides comfort to at least make it available.
yeah.
But that's a that's completely it holds no water. I mean, again, it's completely subjective. It's because
We're talking about subjective things here.
correct, but I mean, but we're talking it's to justify a complete deviation. I mean, to justify allowing doctors participating in suicide, in death, bringing about death. So when you say we relieve suffering and bring about death, if you do it intentionally, you're assisting death, right? Instead of, I mean, we're doing something that the law otherwise. I mean, if there's one thing that the law should do, or criminal law is, it has to do with avoiding death or avoiding killing and whatnot. So killing people is bad, or people killing themselves is bad. I mean, we have suicide lines, all over the place to try to prevent people from killing themselves. I mean, so there seems to be something sort of widely accepted as the norm that there's that life is inherently good and death is inherently bad.
It's
And
interesting
so,
hearing.
yeah, go ahead.
It's interesting hearing you say this. I have one more point about suffering, but I think as we talk, I think one of the things that's clear to me, maybe as clear as I can get, which might underlie, some of the disagreement on this issue, is that, I'm probably a little bit more willing to see death almost as a means to an end. The death is the means to relieve suffering, um, which is something that, coming from the other side of this would be something that it sounds like you could not accept.
Mm-hmm.
Um, because when we talk about um, the means is relieving suffering, giving morphine at the end of life, and the end is death, that's more tolerable, and I understand that.
Yeah, but I mean, if death becomes a means to something good, right? I mean, it's a sort of a consequentialist argument, or the end justify the means, and so forth. But death is bad. I mean, death is never good. Um,
Yeah, I would disagree
death,
with that.
yeah,
I think that we are here,
uh-huh.
for a remarkably short amount of time, um, and there is, man, I mean, innumerable things to make life wonderful and enjoyable. And I will be pissed as hell when my when my days are ending. I expect to be more angry than sad or scared at that point. Um, which I hope is 30, 40, 50 years off, knock on wood. Um, um, but I absolutely can see that time when you say, wow, it is soon. And every single minute of every single day is torture for me. I know what's coming, and why not have that come sooner rather than later?
No, okay, fine. But why bring in the doctor? I mean, right. I mean, my main beef really is physician assisted suicide. I mean, and it's what it does to the medical profession. Why bring in a doctor
Well, let me get you
into
here.
I mean, what's
So
that?
it's a
Yeah,
great
go ahead.
question,
Yeah.
and I think um, that I could, and I have to say, I mean, I feel a little bit like a fraud because, given where I've practiced, I've actually never been called on to do this. And being completely honest, I'm not sure if the laws of Illinois changed, if I'd be able to do it. Um, and it's as you know, it's much easier to argue. Um, when it's really not concrete. But going on, I think that I've taken care of a lot of patients in hospice. Okay, um, and I know how hard that is for patients and for families. Um, we have no information on this, no data on this whatsoever. But I do wonder how often those lives end earlier because of use of medications, patient alone, family and patient. And I imagine, and actually I think it's true that I've certainly had conversations with family members after, where they're worried, did I harm the patient with the medication I did them? Did I did I speed their exit with how I gave them the pain medication that we had? And I can see that having a physician involved with that, even though I agree uh, it's not what we are trained and licensed to do, that could probably also make things easy for the family to
No,
say,
but
I have clear guidance in
I'm
this.
confused here, Adam, because
Sure.
here you're talking about family members having misgivings about uh, um, hastening death.
Yeah.
which tells me that they were not intending to hasten death, right? So there was no intention here of shortening life or bringing about death. And
I'm not
so,
sure.
uh,
Yeah.
yeah, so no,
Yeah.
I mean, they're trying to relieve suffering, and I think the doctors should actually assist them in relieving suffering. That's what we're expert at doing,
Yeah.
and we bring in our expertise to do it in the way that is least harmful as possible,
Yeah.
meaning that preserves life while we relieve suffering.
Yeah.
And we try to avoid, and there's things like palliative sedation and whatnot, and we try to avoid bringing about death, and I think for the most part we can do it pretty well. So you made a comment yesterday, earlier, about somebody tweeting that relieving pain never brings about death. I think that's an overstatement. On the other hand, I think it's also, we shouldn't uh, I think for the most part, we can relieve physical pain quite easily nowadays, and stay away from the boundary where for the most part. I mean, I think there may be rare cases, but I think they're more rare than not. Um, and besides, it's again, the law, what the law is trying to promote, what this movement is about, is what you mentioned earlier, is to sort of this in advance, in anticipation of suffering. It's not that we want to give people the means to kill themselves while they're suffering terribly. It's we want to give them the means to kill themselves before they suffer, to kill themselves at at the time and place of their choosing, and so
Right.
forth, and be complicit in that.
Right. Well, that's the where physician decision making comes in, and it's a difficult thing to figure out how this gets regulated because, man, I mean, I I am terribly concerned, right, about how these this could be misused. Clearly, the only law that I've really read in any detail is the Oregon law, and clearly the lawmakers and their consultants who wrote that law were as concerned as anybody with the sort of checks that are put on that, with multiple physicians, witnesses, so on and so forth. And I think that physicians would need to be trusted to say, at least that's my feeling, like, listen, suffering is part of the human condition, right? And you may not know that when you're a teenager, but you certainly know that as you get on in life, right?
Right.
We all suffer. That is part of living. Um, and I unfortunately have to say that to my patients occasionally. Um, and so, right, so a patient who has been diagnosed, let's come up with something, with pancreatic cancer and is currently doing fine, who is asking to go forward with this now because maybe in 18 months they may need to consider this, I would say, absolutely not. That's not what we're talking about here. We are talking about people who are beginning to see what the end is like, beginning to feel what the end is going to be like, um, recognize that what we're able to do with them is not what they want, and have control of it
but
then.
but again, I mean, can't have you read Ira Byock's book?
Yes, I have actually. Yeah.
I mean, people change. People's attitudes, how they feel about suffering. I mean, people anticipate one thing, when then they go through it, they realize it's not as bad as they thought it would be, or vice versa. People can suffer terribly until the bitter end, and so forth. So there's no way to anticipate people's suffering, and
But
and
this
then to
is
give them the means to do it runs the risk of um, that on a moment of a temporary moment of anxiety or despair or whatnot, then they kill themselves.
but
And
you forget this is at the end of life. I mean, I think that, boy, that is
yeah,
absolutely true.
but it doesn't. You have people who
Yeah.
suffer. What about somebody who has terrible depression? I mean, there are people who have really, really intractable depression, and they have no bodily, no terminal illness, and then they say, well, my prospect of suffering like this is, if it was 6 months, I would take it, but I'm going to be like this for years to come.
No, 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 no,
right?
no, no, no,
And
no.
so,
That I got to stop you. That's not an argument. I mean, every law that's been passed has made very clear that if there's any concern for psychiatric disease, depression, that needs to be treated. That needs to be,
but
consultants
see
need to
what's
be
happening
provided.
in Belgium and the Netherlands. I mean, they started off with a very conservative
Wait, wait,
physician
wait,
assisted
wait.
dying terminal
No,
illness,
you're not going to pull me into this.
right?
Because I agree with you. Listen,
Yeah, but no, but there's an internal. I mean, all I'm pointing out is that there's an internal logic that if you see death as an acceptable means to bring about suffering, there's an internal logic that says the terminal illness is arbitrary. To say, oh, only 6 months or only for cancer, or only that's arbitrary. I don't see
no, no,
why.
no, no, no. You're making a very nice argument that in a college philosophy class I would talk about for an hour. I refuse to accept it here because what we're talking about is we're saying, you are going to die in the near term, and there is no. And this is what I believe, and we can believe totally different things about this. There is no benefit to the suffering because with, let's say, 3 weeks left to your life, it's not that on the last day you're going to say, boy, I'm glad I suffered, and then pass the next day. That's not worth anything to me. um,
But how do
I
you know
am
that? I mean, how do you
fully.
know? No, 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 no. Wait. How do you know that?
I do not know that. This is
Right. So,
subjective. This is a patient's decision, and a
right.
patient should, I really feel like, should be able to make this decision because I think your stance is that, oh my God, there's uncertainty. You might miss a day of peace after your terrible pain. But where do you
No, no,
get
but
the authority
again,
to say that?
why bring in the physician? If somebody wants to commit suicide, it's very simple, Adam. All they have to do is stop drinking water, and I mean, death is the default. Death is the default. Death is what we're all every day battling against, and we do that by our actions, our intentional actions of drinking water and eating food. And if we don't do that, we die. So there's no expertise. There's no need for assistance in somebody who has their full mental capacity.
Yeah.
They don't need assistance. They can simply stop drinking or stop eating, and then they will die if they're serious about it, if that's really what they want to do. If they have no, they can do that. Even then, I mean, I personally would not recommend it. I don't think that's what they should do. But they don't need to bring in the argument that I mean, to ask for the assistance of the medical profession, and in doing so to really inflict a deadly wound to the medical profession, because now we move from being people who you know uh, not only, I mean, not just relieve suffering, but relieve suffering by preserving or trying to
Yeah.
preserve life, so
I don't
forth,
think
and
you.
things
I
that
don't
are
think.
objectively good, into becoming purveyors of something that is really at best really at best murky and
Yeah, I don't think you believe that argument because the obvious
no, absolutely,
response.
I believe it. What do you mean?
No, no, no,
Yeah,
you
go ahead.
don't. Because listen, because the obvious response to that would be, okay, physicians shouldn't be involved in this. So what's going to happen is that states will license end of life professionals who would be in charge of guiding patients in their suicide.
Yeah,
And
at least I won't have any part in it. I mean, because you're absolutely right, and that's actually what people are advocating. There's Timothy Quayle, who's been a long
yeah,
time advocate of euthanasia and physician assisted suicide. He was interviewed about a year ago by Art Kaplan on Medscape, and then he was trying to answer the question, how do you how can we judge that really it's the right decision for a given patient to assist them in this and whatnot. And he was saying, well, listen, psychiatrists can't do that because they're too busy, they don't have the training, and the primary care physicians can't do that because also they're too busy, they only have 12 minutes per patient and so forth. It has, we have to train specialists in this who will go, who will evaluate the patients, and that's what they have in the Netherlands. They have they're trying to promote sort of a traveling suicide assisting physicians, right, who would go around and find out people who are terminally ill, and then
Yeah.
uh, uh,
You
make
see,
that happen. So that's going to happen. But I'm trying here, really, my point is to try to preserve the medical profession the way I want it. I mean, if I'm going to be associated with uh, a profession and lumped with a body of physicians, I want that to be meaningful, and I want that to be a good thing. And so for us to be told that it's a good thing to help patients kill themselves, I think that's crossing the line, and I think it's destroying the integrity of our profession. And so,
yeah.
fine, the government wants to license people that are not who are not doctors. I think they can easily give dispensing machines. I mean, they can be, I mean, because so far the argument is all about the subjectivity of the patient. Letting the patients decide, that they don't want to go through this anymore, and make it easier, maybe not drinking, and not that's too hard. They want something a little bit easier. Well, they can go and get a dispensing machine, or they can have an executioner licensed by the state. That would be perfectly fine with me. But I don't
You're,
want to bring in the medical profession and to
you're,
really
you're,
destroy or distort what the goal of medicine is.
yeah. I think you're making an argument which you don't believe, because you came into this being very clear that um, that you think it's wrong
Hmm.
for people to, let's say, unnaturally end their lives. Agree?
Yeah, right. To
Okay,
take correct to take
right,
action to end their lives, I think is wrong. I agree.
right, and I absolutely agree with you there. Okay,
Okay.
um, but I also recognize that life is complicated, that we sometimes have to make decisions that we're not completely comfortable with, and and I also absolutely agree with you that, boy, I know why I wanted to become a physician. I know what medicine stands for me, and being involved in the end of people's lives, is not that. But I think that if this is something that we are going to accept as a society, that there are some people who want this, that there are some people who don't want to go through with weeks of what I would consider needless suffering, that I have such a high um, opinion of the medical field that I think that people who've had our level of training, our thoughtfulness, our expertise with medications, that we're the obvious people to be in charge of this. I don't want people to be going to the same office where you get your license to be a hairdresser to get your executioner's license with
Yeah,
a
right.
4-week CME course. That's
But
horrifying to me.
but in practice, this is what will happen, because in practice, um, uh, people who are ambivalent will not want to be
Sure,
dealing with that.
sure.
And people
I
who are
expect.
actually, and there are activists within the medical profession. I mean, there are doctors who are absolutely activists on this issue in favor of physician-assisted suicide and euthanasia, and they will be the ones leading the charge and telling patients that yes, we can provide this for you, and they will be doing it. So in essence, it'll be de facto, um, the doctors who are most in favor of who see death as a good means,
Yeah,
um, who will provide it.
yeah, and
And you won't have the ones that the Ira Box of this world, who will do whatever they can to try to relieve suffering, existential suffering, because most of the time it's not actually bodily suffering. I think that's actually quite clear, that most of the time it's existential suffering that people feel, are tormented not by physical pain, but they're tormented by the uncertainty. They're tormented by the idea of being a burden on their loved ones. They're tormented by the idea that they will lack dignity because they've lost. They're going to lose their mind and their self control and their bodily control. They find that undignifying, And that's really, for the most part, that is what's causing all this suffering.
Very well.
And by assisting them, we're telling them, yeah, well, you're right. You're right. I mean, these concerns that you have, these torments that you have, are legitimate. You are right to think of yourself as undignified when you lose control of your bladder or your mind. You're right to consider yourself undignified. You are right to consider that you will be a burden on your loved ones. You are right to consider that all these existential uncertainties. That's wrong. That's wrong
Yeah.
for doctors to do that, because obviously, and that's the point that's being made by uh, I think quite clearly by the disability advocates, that listen, if you're telling those patients, if you're confirming to those patients that it's undignified to live when you're disabled and so forth, well, what about us? What about our children who are born with severe handicaps and whatnot? Are they undignified too? Should we suicide them as well? Which
Okay.
again,
Uh,
that's what happens in the natural history in the Netherlands and Belgium, is that it's once
Hold
you
on,
open the
hold
door, it's
on, hold on.
go ahead.
You gotta stop with the slippery
Go
slope
ahead. All
arguments
right.
for me. Um, I'm really talking to you about care at the end of life. I absolutely recognize the slippery slope, and man, a slip into eugenics here is not what I'm arguing. Okay.
Yeah, I know, but
Um,
the point
so
is that
let me
I'm
say
not. Go ahead. Go ahead.
the
Yeah.
2 points that I do want to make just from what you said, because a lot of, obviously, I mean, I respect you. A lot of what you say really hits home with me, but um, I don't separate. At the end of life, I don't separate existential pain from physical pain. In someone who's been treated for depression, or who is not depressed but is just absolutely bereft at the idea of what their end is going to be like, of you know loss of dignity, of fear of the unknown. I think that's just as bad as unrelenting abdominal pain, and that's fine to ask for a way out. I
Yeah,
also
but
I
don't you
also
think that it validates? I mean, you think I totally agree that the suffering is as bad. It's probably even worse. I
Yeah,
think the suffering is likely worse than abdominal pain or bone pain from metastases and whatnot.
sure.
I don't dispute that, but um, but we I think it should be it's off limits. What I'm saying is that it's off limit for doctors to essentially um,
Yeah, I get it. I
validate
get it.
this position. Yeah.
The other point, I'm not that concerned. So I do agree that, the way this works best, as a generalist, as a primary care doctor, the way this would work best is like, I've seen Dr. Citu for 20 years. Over that time, we've treated X, Y, and Z, and this guy understands me. And now at the end of life, he's the person I'd like to be going to have these discussions and to help me end my life if possible. And that the ideal is not that you go to your doctor and your doctor says, that's not something I do. Let me refer you to Dr. X who
Mm.
does this. Um, that's not the ideal, but it's a little bit what we already do with hospice physicians. It's certainly what we do with abortion providers, where there are doctors who say, I'm not comfortable with this, but we have people who are pros at this, who have a lot of experience with this, and it's not going to be someone who you go to and they're going to say, okay, here's your script, good luck. They're going to be people who are dedicated to this and do a wonderful job at this, and will assess you appropriately and maybe actually do a better job at providing um, a good death, a dignified, painless way of going, than your regular doctor, who might be an expert at treating your hypertension, diabetes, and osteoarthritis, but is either not as good or not as comfortable with this.
Yeah. Although I don't know. I actually don't buy that. I think I don't buy that. I think the people who specialize in this are going to essentially give the script. They and again, I mean, I don't know why you don't take it as valid. The argument of the countries that have done this for the last 15 years. I mean, they're the experience of looking at what happens in countries, and what's happening there is that there's specialization of physicians providing the service, and then there's a huge increase. So you're talking about the slippery slope. To me, it's not a slippery slope argument. I mean, it is in a sense, but it's a categorical change that may not at first be fully manifest, right? So the first few years that you pass the law, behaviors don't change, but over time there's an internal logic that has been unleashed, and there's the internal logic that will make it more and more widely available to more and more people, and for for reasons that are more and more removed from the ideal scenario that you mentioned, meaning end of life, 3 weeks or 6 weeks or a couple of months
Yeah.
before dying, that you do this. That's not going to happen. There's no internal logic to keep it that way. And internal logics are very important. I mean,
Yeah.
because people will say, hey, wait a minute, why? If it's a good for that person who only has 3 weeks to live, why isn't it a good for me, who are I'm going to be facing my own subjective existential suffering that is much worse than metastatic pain, for the rest of my life, and I should
Yeah. Yeah.
do it now. So
Yeah, yeah. I'm seldom an optimist, but I'm more of an optimist than you on this one. And I think our our national experience so far has has been, from my point of view, acceptable. Um, this is something which
although
changes.
again, we don't know the data.
You
What's
know,
the
or,
data?
Oregon actually keeps quite good data, and it's 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 a very limited group of patients. As far as satisfaction, the satisfaction with the process is high. Um, there is some specialization in this, but it's mostly specialization as far as, look, here are geriatricians who deal with this, here are oncologists who deal with this. And I think it's something that's hard to predict because it depends a lot on the underlying beliefs of the society. I think it depends on the sort of religiosity of the culture to begin with. And it's hard to predict how that's going to change over time.
Right. But I mean, I can't imagine the data not looking good because who's going to complain, right? I mean, it's, everybody's going to be very nice. The patients are going to receive their, terminal dose, and they're going to, not be around to fill out the surveys afterwards. And the statistics are going to be kept, more or less. I mean, I don't know about Oregon. I know in California, on the death certificates, you're not allowed to put suicide as the death, as the cause of
Right,
death. You have to
right.
put the under. So you have, again, to sort of play with the truth and obfuscate things, and make a danse macabre, around all this. Let
Yeah,
me ask you one more thing, Adam.
yeah.
Is, by this reasoning, should doctors be involved in capital punishment?
I am completely and utterly I would say that in all of my opinions that have drifted over time, one that I am profoundly stable in is my opposition to capital punishment. So I think nobody should be involved in capital punishment, and we as physicians also should not. We are
Okay,
there for
but
the benefit of people.
why? Suppose you have an inmate on death row who doesn't want to be, killed by a butcher who doesn't know what he's doing and so forth. He wants a doctor who can help
That's
assist.
ridiculous. Nah,
What do you mean it's ridiculous?
no,
It's
because listen, the person's, I would say that the punishment for the crime, as a society, we shouldn't systematically take lives of healthy living people, and so that person, their punishment should be, to live out their days in a place that they can't harm other people. So I will stand on that. And also, I feel
Yeah,
like
but aren't
it,
doctors currently? I mean, doctors are currently participating in capital punishment.
I don't even have any idea, and if they are, it's
Uh,
wrong.
yeah, but that's what happens. I mean, because people make the same argument. They invoke. They
Yeah,
say,
but
"Listen,
there
we want to minimize suffering.
there are
So we
also
want the doctors who will
doctors.
give the barbiturates at the end of life
There are
intravenously."
also doctors running Medicare mills, and there are also doctors prescribing, fentanyl
Yeah,
lollipops to
and it's all
every
it's
patient.
all correct, and
So
that's why we need to be very clear about what medicine is about.
you
That's
want me to say something which will keep you up all night, and you'll be
uh,
like grinding your teeth?
oh no, go
Um,
ahead. Yeah.
this is why we need government regulation.
Yes, absolutely. I agree. I mean, that's to me, it's a failure of. I mean, because now all of a sudden we're condoning some form of homicide under particular circumstances, which is absurd, right? So is the government relinquishing? I mean, the one role that the government has, it means to impose the law in a just way and prevent homicide and suicide. There they go, and we've helped them create philosophers, ethicists, physicians, government bureaucrats. I mean, whoever is in favor of this is helping create something that is absurd and contrary to what government should be doing.
So that
Government should be doing right.
everybody's against you.
The one time that I want the government to do something, they fail me.
I know. Michelle, it's actually
It's
been a
great.
great
Yeah.
conversation. It's
Likewise, I appreciate it very much.
such a hard topic, and I love to get your thoughts. Love to hear sort of where
Thank
it
you,
is.
Adam, for being brave. And I don't know. I can't guarantee that we'll have any listeners. It may be the least downloaded episode of the Ekal and Koka report, but well worth it for me.
People won't admit if they listen to it. We will someday have to talk when we're not being recorded. I think
Oh, I
should
love it.
be. Okay.
Anytime. Thank you, Adam.
You take care.
You too. Bye.
Bye.